I don't know, we're going to prepare some things.
You mean the Congress, the AMBA Congress, doing it online or
No,
something like that?
not at that level. You know, it's a 50
It's super complicated, man.
speakers. Yeah.
I went to Mexico, Leon, and
Ah,
Leon is a huge thing. And those guys had a lot of trouble. They had 18,000 people, but it was a really, really complicated thing. A lot of technical, because there's a lot of factors who are not in your hands. You
yep.
can have everything perfect, but it depends. A lot of people, especially young people, use the phones to connect, and the
Yeah.
phones depend on the system, the internet they're using, and they overload the system. It's quite complicated.
I've seen you on the green carpet. I've done that 2 times, and that's really, really, yeah. If at the beginning is fun, but staying on that carpet like for 2 hours.
Yeah, I get there and they made me because the original idea was going alive. Then
Yeah.
they realized it was a problem, so they decided to record it. I had to record 6 lectures
Jeez.
after arriving, and I arrived there like at 3. So I record lecture until 11 the night before, and they start putting. And it was, I mean, I understand the point, but it was really exhausting.
Yeah, I know. I've done that, and
It's yep,
I wouldn't do that
complicated.
again.
Okay,
Okay, 10
let's go.
o'clock. Thank you for guys for being here, and we have
You open?
150 people for the moment, and that's good. Going to start with a short intro. We have a 24 webinar series. We have started in the 11th of August, 19 amazing people. Thank you, thank you, thank you again. And thank you, Liz, for being here. Thank you for your mentoring, inspiration, friendship, and everything you gave, not only to me, to all Eastern Europe guys and all doctors all over the world. Thank you again for being here. Thank you again for being part of this amazing event. Thank you for inviting me a few months ago in that amazing event on nephrology. You see 19 great doctors here from 10 beautiful countries that I hope we can visit again. And
Yep.
we have 16 different specialties. We have 24 webinars, 120 EMCs, 5 EMCs per webinar. And these 4 great companies that we have to say thank you. Hills, Purina Pro Plan, MSD, and Royal Canin. And Royal Canin is the main sponsor for this event here. Thank you, Royal Canin, for sponsoring this event. Thank you again, Liz, for being here. This is a great, great opportunity for me to meet again an amazing doctor, an amazing speaker, a good friend, and an amazing mentor. Thank you again. Next week, we'll have Kosti Fteme, how can we properly diagnose cats with stertor and snoring, and my professor, Professor Alexandru Diaconescu, medical treatment of pyometra in dogs. Sometimes the scalpel is, guess what, useless. And then we have Luigi. Luigi, one of the best guys I've ever met in my life. Always laughing, always positive, an amazing speaker. Guys, this is all from me. Don't want to get you bored. We have a great opportunity to listen to one of the best emergency guys in the world. Thank you, Liz, for being here. The floor is yours. Good luck.
Thank you so
I'll be
much.
here the entire time.
Well, thank you so much, Alex. Thank you to everybody. I got a lot of messages, as you say, from all people all over the place there in Europe, East Europe, Bulgaria, Turkey, Romania, Russia, Serbia, Croatia. So I really appreciate all of you guys. And these weird times, I think it's really, really important that we stay close together. Yeah, we are living. Remember this. Eventually, we're going to tell to our grandkids, we survived this. You can believe it. We survived it. So I don't want to waste more of your time. We're going to talk today about fluids. Let me share mine. And I'm going to go from this. Okay, can everybody see this correctly?
Yep, it's perfect.
It's perfect. Okay. Perfect. Okay, let's go. Uh, why I want to talk about this? Because it's freaking complicated. The more we talk, the less we know. So fluids is probably one of the most variable things that happen along with antibiotics, and in general in sepsis probably is the where more information is produced, where still there's a lot of questions. So I have to warn everybody, I have a lot of questions because there's a lot of questions that still non answers, and I'm gonna try to show you today the evidence. Unfortunately, it's very common that people say, well, I'll do this and it works for me. I don't care what everybody said. This is what I do, and that's it. I'm gonna try to give you a little bit more evidence, science evidence perspective, what we really know, because as I told here, still there's a lot of questions that the answer is blurry, is very gray, no black, no white, there's a lot of grays. So the first thing is why is fluid. There's no other treatment or medications who can save more life than fluid therapy. And that is a lot of evidence behind this. However, in the last year, we have to add two things. When you use it, okay, when we use it properly, but also when you monitor properly. We realized lately, and when I say lately, is in the last 20 years, that we did things that were pretty bad in the past. We killed people, we kill animals because the way we use fluids, because we had this crazy idea that fluids were harmless, that, oh, no, nobody cares, it's just water, no worries. And just give it, we can see later. And I remember those times. I remember many years ago that you put the dogs, and in every hospital was like that. They put the dogs with fluids or the cats with fluid, went home, and you come back in the morning, the dog was dead. And you never think was the fluid. You always thought it was, no, he was really sick, and probably he was not surviving anyway. And you, of course, we're doctors. We never blame ourselves in this. But there's a lot of myths too. One of the myths more common is if you give it 1 drop per second, click, 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 it's gonna be safe. And that was a myth that came from humans and actually came from pediatric medicine. So we use it and everybody did that. Let me show you this. Mishka is a very young male, 45 kilo, big boy. He comes to the hospital yellow, all the liver enzymes are high. We realized with ultrasound that there's blood in the abdomen. Blood pressure was really low, 65 systolic. And the resident at that time decided to start in a safe ground. Safe at that time was 1 drop per second. They were doing pumps, etc. So if you are using a micro drip, not a pump, and you give 1 drop per second, that means you give 60 drops per minute. That micro drips, every 60 drops is 1 ml. So you are giving 1 ml per minute. If you give 1 drop per second, that means in 1 hour, you give 60 mLs. That's okay, but this dog weighed 45 kilos. That means you give per kilo 1.3 mLs per kilo per hour. After 2 hours, he died. Then we realized that he was bleeding because he had a small rupture in the liver. And we have to realize we did nothing. Nothing. 1.3 mLs per kilo. There's no way in hell that we could save Mishka. And this happened multiple times, especially in traumatized patients during that time that we try to play safe. Why? Because in all the movies, it was 1 drop per second. It has to be safe. It was not. So what is the optimal fluid therapy? Is still the most enduring controversy in medicine, human and veterinary medicine. What type of fluid you should use, what is the right rate of administration, and how much is the total amount of fluid that you have given. This is something that we never pay attention. We always thought that you give enough fluid because the kidneys is going to take care of that and it's going to eliminate whatever the body doesn't need. That is not true. We realize today this is one of the most hurting ways that fluids attack the body, overload. And we always have to put what science said and clinical experience. Again, I have a lot of colleagues here who say, well, I don't care. I do it like this way and it works for me. the problem is you don't see the dark side with that, because if you die, you never think it was you. You always think it was, no, the dog was very sick, or the cat was never survived with this, etc. And the other point about optimal fluid, and there's a lot of new data coming, new information about new research who say, oops, and the majority of the news information just show that whatever you did last year was wrong. So, and there's some examples here, the new information about colloids, the new saline, the glycocalyx, the plasma, transfusion. There's a lot of that. Sorry, 1 hour to expand this is a very short time. So what is the optimal? There's always a rational or logical approach. Sometimes it's a little naive. We follow exactly what happened, and we forget a rule that one of my teachers told me, Dr. Michael Sharon Florida always told me this: hey, neither dogs or cats read the books. So think about it. Even if the book says something, every patient is different. So make this more personal. And these are most common discussion, fluid compartments, how the water distributes inside the body, and what is the normal physiologic response. If you guys have an accident, and that happened many times in humans, that's one of the things we learn in the multiple wards. There are some books about the usage of fluid therapy for resuscitation in wounded soldiers in Vietnam. It was terrifying. They gave it an enormous amount of saline. That was the standard, the protocol, 7 liters of saline in 2 hours. Of course, this guy's gonna die. So what was the normal physiological response for that? So still thinking what was possible. If you're gonna read, there's an enormous amount of reading that you can do. Unfortunately, not all the reads agree that colloids are dangerous, and others say, no, they're not dangerous. It's not the colloid, it's the amount of colloids, etc. There's a lot of new reviews of classic literature. For example, the SAFE study, who was studying humans about traumatized people who received saline or saline plus albumin. And at that time, albumin increased surviving for 4%. Today, they realize with new tools of statistics, and they say, nope, that was wrong. Actually, just saline was better than saline plus albumin. So there's a lot of things. We're going to try to talk a little bit about everything here. This is a very cool review. Essentially, what these guys did is they called like 350 practitioners in all over Europe, and they asked them, what do you do with treatment of fluids? How many of you use? And they put this. In pink, you can see whatever they use very often, quite often. In blue, they use sometimes. In little light blue, rarely. And gray means they never use it. And down there are the different fluids. The first column is crystalloids. The second one, who is HTS, is hypertonic saline. The second one is heterostarch, a colloid. The fourth is a dextran, another one. The fifth is another colloid called gelatin. Sixth is albumin, and the last one is plasma. As you can see, the large majority of clinicians in small animals use crystalloids more than anything else. But when you're looking for hypertonic saline, who is quite a new fluid for a lot of people, there's more and more people using it. Colloids suffer the impact of the last information and say, nope, I'm not gonna use it. However, still there's people using it. And when you look at them, there's a lot of people using heterostarch that is based on new information. Very few people using dextrans and gelatin. But still there is a 10% of people who seems to use gelatin instead of the other ones. So it's interesting when you ask them, and this has to be anonymous. That is the key. If they know that you know we're gonna publish this, you can get in trouble. But anonymously, this is what they're using. So what is the optimal fluid therapy? You have to think about this. When a pet has hypovolemia, dehydration, or excessive losses of water, or water with electrolyte, the homeostasis is trying to adapt that. So this is the normal individual. inputs versus outputs. And the balance have to be zero. In order for you to do not gain weight in water or to not get dehydrated, your inputs has to be the same that your outputs. So if you keep this in mind, what happened of this system when a dog is hit by a car or when a cat falls from 10 stories in a building? So this is what you need to think. How is the impact? Because essentially what you can do is try to stop excessive output and trying to supplement a little more inputs. That's what you do when you do a IV fluids or whatever form of fluid therapy. Always remember, those individuals do not react the same. And we all suspect this. If you're in practice and you see a dog who is bleeding, for some reason, some dogs look like they have nothing and they're stable, blood pressure is normal, they don't develop sign of shock, the pulse is firm, the heartbeat is not that, etc. What other dogs with exactly the same body weight, with exactly the same cause of bleeding is dying. Really a non-reversible state of shock, blood pressure is going down, lactate is going up, etc. So two individuals do not react the same to the same injury, to the same insult. And that is something that you need to think, because if I'm going to tell you about fluid therapy today and you got to go home with some ideas, it is tailored individually. You cannot use just numbers and formulas, etc. This is something that you need to adjust for your patient that day with that condition. Apollo is a classic German Shepherd, male neuter. He was hit by a car. He arrived to the hospital, then tachycardia of 170, tachypnea 52 of respiratory. Pulses are tall and narrow. That is what we call the hyperactive part of the shock. Hematocrit is 34. That is a little red flag. Lactate is 5.2, pretty high. That means perfusion is affected. pH is slightly acid, and the CO2 is very low. That is classic from those who are panting or breathing rapidly because they're in pain. A fast exam of the abdomen find there is a hemorrhagic abdominal fluid. So what we did, we gave it 20 mLs per kilo of ringer lactate over 15 minutes, and we reevaluate Apollo. The quality of pulse gets much better, heart rate improved from 170 to 140, systolic blood pressure go up from the 60s to 110. And we follow up with another bolus of 15 mLs per kilo over 30 minutes. We are slowing down a little bit, so we keep supporting this stuff. Everything was cool. But a little bit later, Apollo was not that okay. The heart rate increased again to 160. The breathing again becomes a little more labor, and the respiratory rate was 36 now. The pulse again started getting tall and narrow. What we did wrong was not enough fluid. We have to give much, or we give too much with the 2 bolus. Is this about the pain? Is this still bleeding actively and we need to stop the bleeding? So what do you do with this patient is one of the essence of fluid therapy. What do you do now? We reassess this. This is a chamber for oxygen with VO2. He's definitely bleeding. The PCV went down to 22%. The lactate goes up. Remember, it was 5 or something. It's not going down, and it's more acid. His breathing is better, so CO2 is getting a little higher by to normal. So what we do now? We give it more crystalloids, we give colloids, we give transfusion. How much? We found that with the T-fast and fast, that there is a little bit of pleural effusion, and there is more blood in the abdomen. What we do? We just put abdominal wrap. We go to surgery to stop the losses. We get transfusion before. If you don't have blood, this is how you apply for real fluid therapy. Doing fluid therapy in a cat that you're gonna have to spay or hysterectomy who is healthy, this is not about this. I'm talking about seriously sick patients. Okay, that was the title of the lecture. I don't want to talk about the simple one. I'm talking about what do you do with this one? What do you do with this one? What we do normally is we transfuse. In this case, what we do, we went into surgery, we collect the blood, we filter, and we auto transfuse. but also we give a good amount of hypertonic saline to sustain blood. But we drive this thinking how Apollo will respond. So when you develop a fluid therapy plan, think what you try to do with the fluids. What is your intention? What is your purpose? When you decide that it's because it's bleeding, it's because it's losing weight, it's losing fluid, it's because it's vomiting, diarrhea, it's pancreatitis, if for that it's dehydrated. No, it's because it have an enormous amount of diuresis because it's diabetic. So that's why I need to come. So you need to think why you want to give fluid first. And then you need to decide what type, what route, and what volume. And those are not simple questions. We used to do this with little numbers. Oh yeah, he weighs 30 kilos per 7% is 2.1. Forget about that. Those are just general reference. And remember, no dogs, no cats, read the books. And this is my hospital. This is something that we tend to forget. There is a good amount of fluid usage who produce complications. And it's easy to not remember, yeah, fluids are so cool. No, there's a lot of things that can happen. For example, complications related to the method of delivery. Intravenous or intraosseous catheters, they can produce phlebitis, sepsis, thrombosis. The extravasation that the stupid dog move and the catheter is not in the vein anymore, now is subcu, and the fluid that you give it a shot of hypertonic that produce necrosis, etc. There's a lot of evidence that you can produce fluid overload. Cats are very, very prone to that. It's easy to produce fluid overload, and we kill a lot of patients because we give too much or too fast. The usage of electrolytes, we don't care. Oh yeah, it doesn't matter, drink a lactate, hypertonic, whatever, it's the same. One of the things that already we knew now is chloride in the simple saline is not as harmless as we suspect for years. There is a mounting amount of evidence proving that the excess of chloride, too much chloride, can produce a lot of bad things. Vasodilation, hypertonemia, hyperchloremic acidosis. So remember that this is not just water in, water out. There's way more, and you can damage patients with fluids. So what is the goals of the fluid? All of this: replace losses, improve perfusion. The only one who grab the oxygen from your lungs and carry on that to your toes is the blood. And the only way that the bus carry on the oxygen, who is the hemoglobin, get to your toes if there is enough water in the fluid, who is the blood, to reach there. If there's not enough water, those routes start closing. And when they start closing, I mean vasoconstriction. If that happens, your toes never gonna get the oxygen that you wanna deliver to them. So remember that. Water is everywhere, and it's very important for multiple things. This is a very important point too. Treating dehydration is totally different than treating hypovolemia. Okay, a puppy with parvo who is really dehydrated because vomit, diarrhea, plus not drinking, is different to treat that cat who break the liver because he jumped from the balcony and now is hypovolemic. The treatment is different. Both needs water, but both for different reasons and both for different manners. Hypovolemia is related to tissue perfusion. What you can measure that is heart rate. In general, especially in dogs, heart rate goes up. In cats, that's a little bit more. Capillary fill time and mucous membrane color change in dogs. In cats, again, cats never really do. But blood pressure is your main thing. Now we can discuss about lactate too. There's a lot of new evidence how you can measure this without the underestimation of why, how much. There's a lot of ultrasound things looking for cardiac output, cava vein index, who essentially can measure the variability of the cava vein in the abdomen with ultrasound. It's simple, it's fast, etc. But what I'm saying is, if you think it's hypovolemia, you're losing volume, your plasma volume is reducing, and you need to correct that using bolus. Do not treat hypovolemia with constant rate infusion, the whatever mLs per kilo per hour. No, if you have hypovolemia, you need to correct that because very rapidly all these patients die. Dehydration is another game. That water came from the interstitial fluid. This is something that you evaluate by mucous membrane muster. If the mucous membrane are not moist, if the skin fold is fine, if they have enophthalmos or not, those guys needs to be treated by CRI, constant rate infusion. Why? Because you want the water in the interstitial space. In the hypovolemia, you want the water in the vascular space, and those are different animals. There are some signs of hypovolemia. The problem is this: how you know? How you know how much blood a pet lost? There's a good estimate. There are some estimates, but these are the symptoms. If you lose less than 15% of your volume, nothing's going to happen. Your body can keep with that. But if you lose more than 40% of your volume, you're going to die. And those are the symptoms. The fact that there's no blood in a good amount of, it's not the anemia, that's another point. It's not the lack of red cells, it's the lack of volume and vascular expansion. Without that, a lot of things goes wrong. Between many other things, the vascular return, blood return to the heart is reduced. And because that is, there's no preload, there's no cardiac output. And the whole thing goes down, including blood pressure, blah, 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 blah. So think about this, how much blood, how you can calculate that. There's no, I would say, accurate ways to calculate. You approach to this. So if you have a patient with hypovolemia, like this patient who has a hemothorax, you want to correct this as fast as I can because everybody is suffering. All the cells in your body are suffering because they don't receive nutrients, they don't receive oxygen, and they're gonna protest. The tissues in my toes, my intestine, my muscles, who are the first one to, nope, I don't have enough blood for you guys, so I'm gonna concentrate the blood in my lungs, my heart, and my brain. That can work for a little bit, a couple of hours. But after that, my intestine, my muscles, my skin, my toes, they're gonna start protesting. And they protest pretty nice until it's not nice anymore. And then the shock go into the non-reversal form. These guys, we normally treat it with bolus, 30 to 55 mLs to 60 mLs per kilo. We don't give that whole. We normally give 1/3 of that, and we see what happens. EORs is end of points resuscitation. That's mean, what is your goal? If he arrived, is bleeding, you know it's bleeding because it's an amputation, a wound, or there's bleeding in the abdomen, there's a rupture, a splenic tumor, or a traumatic, whatever. You get these 10 kilo dogs, you calculate you're gonna give 300 mLs, you're gonna give 1/3 of that. So you're gonna give a bolus of 1/3, and then you check. Is the blood pressure moving better? Is the lactate going down? Is the mentation getting better? The temperature is getting better, or no? If it's not, you repeat it. But that's the way you approach to this. Dehydration is a different game. Dehydration is most of time a slow process where is excessive loss or a lack of intake. Those are the symptoms, again, minimal, moderate, and severe dehydration. There's a lot of questions today if it's really, really, really true that a pet with more than 12-15% of dehydration is dead. If you read the old books, the rate of death is very high. But we all have seen those puppies with distemper or parvo, or those adult dogs with pyometra or pancreatitis who are really, really dehydrated and still alive. So just remember one thing: when you assess for hydration, all the symptoms, the skin fold, the elasticity, how moist or not the mucous membrane, how zinc or not at the eyes, etc., those are subjective. Those are estimations. They are not perfect numbers, okay? So be conscious about it, that it's not a square, hard data number. Then you have to choose for fluids. And there's a lot of classification of that. There's isotonic crystalloids, fluids, and that's the name for fluids who contain pretty much the same that your plasma or the plasma of your patient has. So they have the same concentration. However, there are some better replacement or balanced fluid than the other ones. Saline is not considered a balanced fluid because it contains a way more chlorine than it should be. The same happens with ring and lactate. He doesn't have enough potassium to be that. So there is a little bit of investigation and develop trying to find or produce better fluids. Plasma-like 8 is one of them, numbers are. There are fluids who looks way more than your plasma. Then this hypotonic, the classic hypotonic is dextrose 5% because it contains only glucose, no sodium, no chloride, no potassium. Okay, those produce and provide only water. The new one on this list is the hypertonics. And the hypertonics, the saline is the most common. Every country have a different one. We have here one who is 7.5%. Some countries have 9% who contains sodium chloride, salt, but way more. Then you have the group of colloids. The old ones are the gelatins. A little less older are dextrans. The most new are the hydrostarches. The highest is the most common, hydroxy starch. And plasma has been put in on this one. And the new generation also was the HB, the hemoglobin carriers. The only one that I know is oxyglobin. They stopped the production. They are really considering producing a new one. So I heard in a few minutes, Dr. Muir was reporting that they're going to start producing these hemoglobin carriers. What is the advantage of this? This thing contains hemoglobin. So you give fluid, but these guys also can carry on oxygen. They're freaking expensive and they have a lot of technical issues, but they're pretty cool. When you give fluids, you need to keep in mind on this, where the water that I'm giving goes or stays. We'll think that if I give it in the vein, should stay in the vein, no? Because I want the water in the vascular space. Not true. The redistribution is very fast. That happens approximately between 1.5 hours and 2 hours. 80 to 90% of the fluid that you put on the vein, because you cannot put it in the interstitial space, redistribute. And this is the way they redistribute. You need to remember that. If you put balanced crystalloids, most of them redistribute, around 80% redistribute to the interstitial. If you put glucose 5%, pretty much 60% of them redistribute inside the cell. So it depends where you're gonna put it, okay? But if you wanna rehydrate a patient and you give glucose 5%, you're not doing what is supposed. The rehydration should go to the interstitial, but not in the cell. What you produce is edema. If you want to produce something to stay in the vascular because it's bleeding, you cannot use glucose 5% because nothing is going to stay inside the vascular. If you use balanced crystalloids like normal salt, around 20% of that will remain in that. But if you use colloids, 100% of them will remain inside. So this information is dynamic, but remember where the water goes after you give to your patient. It doesn't stay. This is a very cynetic thing. Muir is an anesthesiologist, critically is fantastic, an old guy who is fantastic for new information. So he always say, fluid should be considered another medication because it could be fantastic, but it could be very dangerous if you don't know what it is. This is a very classic myth, and this was the fluid therapy during the 80s. And the 80s is, at that time was, if you have a patient who's hypotensive and you give 15 mLs per kilo per hour of crystalloid, you can treat the hypotension. It's not true, prove it, and Archie prove it. And the other myth of that time was like, if you have a patient who was bleeding, you calculate how much blood has lost, and you replace every ml of blood that he lose with 3 mLs of crystalloid. So if you lose 1 liter of blood, you give it 3 liters of crystalloids. And that was the best way to euthanize patients. A lot of people die, especially again in the war, because that was the rule. And that was a rule based in experimental data, not in real patients, in rats in a lab. So remember, we are not rat. I mean, there are some rats, but they normally work as a politicians, no as a veterinarians. The other thing is, can I measure if the perfusion is going on? I mean, how can I measure the fact that my patient is receiving oxygen and nutrition in the cells of their body? So because that is the whole purpose of this thing. You breathe and you heart pump. The only way for this is to keep moving this and provide all the cells of your body with oxygen and glucose so they can produce energy and survive. When that is not happening, can I measure something? There's not accurate things. Why? Because lactate is the most studied things. There's another ones like microcirculation, but they're late. So when your lactate is still going up, hyperperfusion already occurred. So you cannot anticipate that the perfusion is going down. You can see the effects of that. There's a bunch of imaging things has to do with some biomarkers on this. Blood pressure was one of this, but all of them are late. And this is probably one of the biggest change in the games. This is a game changer, the glycocalyx. For many years, the rules were that your endothelium was a line of cells who are stick to each other. They have pores, and essentially the pores dilate or do not contract, and the endothelium respond to certain things like pressure, volume, and certain cytokines. Now we know this is not that thing. This is the glycocalyx. Glycocalyx is that little membrane tissue, today is considered tissue, who recover every single endothelium in your body. Those little hairs there are a bunch of glycosaminoglycans. I'm not gonna go into little science, but let me tell you this. These things produce so many things in your body that you have no idea. Regulate your inflammation, regulate your response, regulate your blood pressure, the distribution of water. If the water goes into the vascular, goes out, etc. So having a healthy glycocalyx is the best thing you can do in your job. And also, you need to understand that it's a very fragile layer and can be damaged for several events. One of them, for example, is shock. And one of the most damaging things is septic shock. And there's a lot of research of this, especially how can I treat this? How can I protect them? How can I do better things? Reperfusion, ischemia reperfusion really affect this, produce something called shedding. So it kind of like you brush it away. So this glycocalyx cannot do what they do, who is this selective selection on this, and that affect your immunity, the water distribution, your coagulation, etc. I can give you a long. Believe me, if you didn't listen about this yet, you will, because you're gonna hear a lot about endothelial glycocalyx in the next years, a lot. It better, because the companies are studying this, how they can intervene, how can they protect, etc. So in this patient, for years, this question was both. Crystal is colored, both have the same space, colors are perfect, and they retain the water because they don't move from the vascular, while crystalloids redistribute. So when you combine both, it's the better option. Again, this was the safe study in trauma patients and sepsis. There was a couple of EPIC study who investigate this too. Today, there's a lot of questions about this. This is 2014, only 6 years ago. And at that time, all the information we have about colors comes from humans, and we didn't suspect what was coming. In humans, they already seen some stuff about risk. One of the things that happen in humans is that we don't do in veterinary medicine is they follow long-term their patients. If they have a patient with sepsis or trauma or hemorrhagic trauma, hypovolemic shock, etc., and they do whatever they do, then interventions, fluid, oxygen, ventilation, blah, 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 blah. They follow that person and they check what happened with them 6 months later or 1 year later. In veterinary medicine, unless this is a university setting, it's very rare that you make the connection with something that happened with Bobby, who was hit by a car. I treated, I saved it. If Bobby had something else 1 year later, the connection what I did 1 year before is very rare. In humans, they do that, and they start realizing that, oops, something is going on with this. For years, we thought that that was the best way to provide oncotic pressure in pets who have low levels of albumin. Dogs with hypoalbuminemia needs more oncotic pressure because it's the albumin who produce 90% of the oncotic pressure inside the vessel. So we said, use colloids. These guys investigate different levels, 1 ml, 2 ml, and 3 ml per kilo for every 24 hours, and they didn't see one little change on the oncotic pressure. And it was like, what? So the combination of this is, can we measure fluid overload? If we, instead of using colloid because of this, can we use fluid overload? Detect it? There's no way to do it. The best way to do it is clinical. There's no specific test. If you have a cat, and this is the second message that I'm gonna give you. If you have a cat that is gonna need, or a puppy, or a young dog who's gonna need a very aggressive fluid therapy, because whatever reason, weight him, has his body weight, is probably the most secure method to determine. If you have a German Shepherd, 30 kilos, that have pancreatitis, and you say it's dehydrated 10%. So if you're right, when you rehydrate, it should be 33 kilos, because you're replacing those 3 kilos that he lost or she lost by dehydration. But if you weigh the dog 2 hours later and he's weighing 35, you probably are going too far with the fluids. And you're gonna realize that those numbers don't make sense. We've been doing this very, very, very often now. And a lot of times you say this pet 30 kilos is 10% dehydrated. You weigh it again after 4 hours and now he weighed 31.5 and the rehydration is almost normal. So you realize, whoa, so what was wrong here? The redistribution of fluids, it's different than what you have in your mind. And again, glycocalyx play a very important role in that decision about moving waters. We don't know still yet, but my message, wait your patient. And if it's a cat, do not only wait, auscultate the thorax of your cat and the fluid. If you give in 1 drop per second, it's not important. But if you give in a very aggressive fluid therapy, you need to monitor what's going on with that. Oops. Pumps. What about routes of administration? In my patients, I'm talking about critical, very sick patients, you gotta go even intravenous or intraosseous. There's no time for subcutaneous, enteral, or intraperitoneal. Those 3 methods are too slow and too unpredictable, especially subQ. You cannot treat a very sick pet subQ. It's gonna die. It's gonna go, to the incineration with all that water. So if you're gonna use an IV, remember, change the IV line for each one. We did a research and who was confirmed later about what is better to replace the catheter very often or do a good work, maiming this, cleaning, changing the bandage. So it's very clear now that it's much better if you take care of the catheter, cleaning, replace the bandage, etc., instead of keep changing and putting a new catheter, okay? So always try to keep an eye. If you have gravity flow symptoms, so no pumps, always remember, you can calculate whatever was that, but the position of the catheter is not, it will affect the rate, especially in cats when they retract the leg and that little vein twist, whatever you were dripping is not dripping the same again. So keep an eye on that, okay? Not important. That's a little bit of new things. In humans, they are trying to use as much as possible for oral fluid therapy. either volunteer or through nasogastric tube, burns in people with severe burns. This is one of the ways because it's very physiological. You can provide not only good amount of water, but also some good level of electrolyte. It's very physiological. You very rarely you can overload. So remember that in certain patients is a good alternative. Just keep an eye on that. Oral could be an option. What about the IO? Like many other things, IO come up like, whoa, this is, and it's really cool, but it's not that easy. It requires some good training for your staff because while you put the cath, you need somebody to clean it, those hate it. It's not as simple as we all thought at the beginning. They have some technical issues. The catheter, who is very expensive, get sometimes blocked. Where to put it is a little bit. We normally put it in the shoulder or in the femur. This is a new device, the ZIO, who is this little drill who put it. It's very common in humans now. So if you have an accident and the nurse come back with a drill, be ready. They're gonna drill you. And for some reason, people said that it doesn't hurt as much, but don't volunteer me for this. There's no way in hell you're gonna put me one of these. But we do that. Again, the drill is not expensive. What is really expensive is the cath, because the catheter came with a little trocar inside. Essentially, you go intraosseous and then you remove it. It's easy, fast, etc., but it's not as simple as everything say. If you don't have the IO, you got to go with the cath, and this is the position. In young individual, it's very easy, and old individual is pretty tough because essentially the bone is mineralized now, and you got to go through that. So my only recommendation, if you go with this one, is safe. If you're in, just take an X-ray to prove that your catheter is where you want to have it. Okay, I see cats treated with this, with the catheter supposed to be in position and actually was parallel to the bone, and he developed a huge edema and ectasis on that leg. So be sure that is when it is. If it's in the osseous space, in the endosteum, it works like it's IV, and that is fantastic. You can give drugs, you can give nutrition, you can give fluids, transfusion, etc. So today, you treat these patients in 3 stages. This is what you do with your fluid therapy: resuscitation, rehydration, and maintenance. What is this? These are overlapped. This is not like one end and you start. What is resuscitation? First, why to me it's important that you understand this, because you're going to hear a lot about this. What fluid are you going to use to resuscitate? Oh, we resuscitate with this fluid. We use ring lactate to. What is the meaning of that? The meaning of that is, if you are severely dehydrated or severe hypovolemic, part of your cells are dying because they do not receive perfusion. Because they're dying, when you start the fluid, what you want to do is resuscitate that part of your body who are not receiving perfusion. That's the meaning. I'm going to use to resuscitate to reestablish perfusion and tissue oxygenation, so those tissues can start again producing energy and produce life for themselves, protect them, membrane correction, metabolism, etc. What fluid to use? That is the big thing today. I could say the large majority of in veterinary medicine and human medicine use crystals for this. How much and what is the end point? So you give until what? Depending on what is the cause of shock. It was hypovolemic, it's septic, it's reduced distribution, it's embolic, it's dehydration, etc. When you do that, the second stage starts, which is the rehydration. Most of the time, the water in the glycocalyx plate this has been taken, the vascular, a little bit of water from the fluid bank, who is the interstitial space. But the interstitial space really want the water back. So when you start putting fluids in the vascular space, the interstitial start immediately recovering what he's already lost. So that is the rehydration. You always need to follow that with isotonic crystalloids or balanced fluids. And then you have maintenance if the dog is still bleeding, or if the dog is still vomiting, or still have diarrhea, or still have polyuria because it was blocked, or he have diabetes, coaching, whatever. You still need to provide that water, and that is maintenance. Okay, so resuscitation, you reestablish perfusion. Rehydration, you pay the debt that you acquire with the interstitial tissue, and maintenance, you keep repairing the losses of water. So remember this. We all have one of the professors many years ago who said severe ill patients should receive the shock dosage of fluid, 80, 90 mLs per kilo per hour. Very, very, very few patients will need this. And if they need that amount of fluids, you don't want to give it in 1 hour. You want to give it in bolus. The only ones who will need this is probably hemorrhagic shock, and those guys need bolus, no rate infusions. So this one, as they say here, is a little more the wizard than medicine. There's a lot of evidence. And if you try to read where the number came from, it's a very, very dark past that was responsible for that. So remember this, the approach of fluid therapy is individual, personalized. You need to measure. So you give the fluids. What happened with the fluids? You bring that dog, Apollo, who was bleeding. You decide to give 20 mLs of blood in a fast infusion. You give the blood. What happened this way? Is the pressure getting better? Systolic pressure? Is mentation getting better? Is lactate going down? Is the temperature getting better? Etc. So don't just give the fluid, check what happened with them. Okay, and then replan. The same when you have a dehydrated patient. If you have a pyometra dog who is coming to your hospital and is very dehydrated, and you say it's 10%, it's a Rottweiler who weighs 50 kilos, and you start giving fluids. After 2 hours of fluid, you probably give 2 liters of fluid. The patient that you have in front of you now is totally different than the patient who walked in. Now you have a patient with half of the dehydration. Likely he should have better. So monitor, is the fluid doing what you expect the fluid was doing? Okay, and look for things. In Latin America, I always make jokes about this. The only way they check that is they go to the cage and say, Baba, oh yeah, it's much better. He's wagging the tail now, the ears are up, it looks so much happy. Please use endpoints. Endpoints means albumin levels, systolic blood pressure, lactate levels, mentation coma status like Glasgow. Do something that you can quantify to see if your pet is doing better. Remember this, again, cats are not really good for aggressive fluid therapy. They're really predisposed to overload, and there's a lot of evidence about overload. This cat who was hit by a car, what the intern decided to do is the right amount of fluid, but he used dextrose. And dextrose, please, as you say here, it doesn't have any sodium. So all that fluid, when you give it, goes straight to the cells, not to the interstitium, not to the vascular. So, Hank, check where the sodium is. It's 119. It's a severe hyponatremia. And severe hyponatremia is really gonna mess with your brain. So please, Dextro 5 is not an energy provided solution, and it's not a resuscitation, it's a fluid resuscitation at all. You just provide water for your cells. This is a very nice study. It's published in 15, who is how good are we giving potassium supplementation in dogs or cats? Who needs that? The classic is the one with diabetes, or the one who have treatment by insulin therapy, etc. So keep an eye on that. They catch a bunch of mistakes in the amount of potassium that they provide. When you treat cats with fluids, keep always an eye. Severe hypokalemia in cats make you look like he's dying because he may die. So just remember that cats are very fragile individuals for fluid, especially if you are aggressive. A couple of touch. This is a couple of new fluids. There always was a question for blood cats. You probably see a lot of these cats who get urinary blockage. They get you do chemistry and electrolytes. The urea is 190 and the creatinine is 8, but the potassium is 8.5. So always was a concern if we should use fluids that do not contain potassium, or should we use a balanced fluid who contain a small amount of potassium. What this one proved is it doesn't matter if it contains potassium or not. It's the fluid effect what you want. So you want the kidneys to start working on it. So you unblock the cat and provide fluids with potassium, because still the potassemia, the potassium in blood, will go down. There's no difference on how the potassium will decrease in plasma, okay? This is the other one that also was provided about blocking cats, is you need to remember when you unblock a cat, there is a severe diuresis after they lose a lot of water. So many of these cats needs to remain in the hospital after you unblock, only to receive fluids. Or the clients will call you and say, hey, my cat seems to be diabetic now. He is drinking and peeing like crazy. Just remember, post-obstruction diuresis is a common thing in cats after block. The crystalloid colloid debate, there's a lot of data about this. I'm not going to go into the details of this. What they prove is colloids really interfere with coagulation, and there's a hypocoagulation status. The mechanism, there's a lot of theories, but this is what happened in humans, has been proven in dogs and cats. So the use of colloids, you should be prepared for some coagulation issues. This is compare hypertonic and isotonic fluids for resuscitation. This is a working horses, but it's the same. What should I use? Remember, resuscitation, you want to bring perfusion to those cells who are not receiving blood because there's not enough blood. And these guys prove that the hypertonic is a very valid, good alternative. This one is a study that follow what happened in humans when they follow humans who have been in severe dramatic hypovolemic shock. They treated with colloids. They follow 3 months later, they develop acute kidney injury. And for many months, we say that is a problem for humans, doesn't happen in dogs. Well, Carol Matthew from Wealth proved it that it's the same. So this put a big step back for colloids and veterinary medicine, because they prove it that also happen in dogs. The question is it's depending what type of colloid, or it depends what volume you give? The answer seems to be, there's not an answer, definite answer, but the total volume per day seems to be the key for this. But I'm just telling you. The hypertonic saline is really cool. He drag water into the vascular, so produce a very rapid expansion, also produce a lot of hypernatremia. So you have to compensate. We use a lot of this. This is what is replacing colloids now. We normally use 40 mLs per kilo over 20 minutes, over 20, 30 minutes. It works very nice. Blood pressure goes up, mentation goes up, perfusion goes up, lactate goes down. Don't give it too fast, because that can produce vomiting and fluid overload. Remember, you put a lot of salt inside the vascular and it's going to steal water from everybody else. You need to pay that water later with balanced crystalloids. But they found a few things also about this. The hypertonic seems to produce another good night things. I'm going to talk to you all the day. Okay, so this is the one of the futures. So as a summary, be familiar with what fluids you have, crystalloids. Remember what crystalloid you have. If you have colloids, if you want to use it, synthetic or natural. You have to treat different hypovolemia from dehydration. If you have hypovolemia, use bolus. If you have dehydration, use constant rate infusion. Do not use the stupid numbers that the double of the maintenance, 10% of this, 10% of that. And always follow goals and end of resuscitation objects, okay? So blood pressure, lactate, temperature, mentation, whatever. But follow certain parameters that you can measure and assess after the fluid therapy to see if it's doing what you want to do. Okay, guys, well, there's a little bit of the hypertonic saline. Read it, Google about hypertonic saline. There's a lot of good things. And big thanks for particularly, I mean, the host of this is Romania. I have very good friends down there. Is one lecture many years ago at the time that we put it together. Remember those years when we were all seated in one seat next to the next one? Oh, that was a long time ago, before we're all gonna die. Well, the white workers are coming, the white workers. Thank you so much, guys. I hope it works and it helped you. Alex, I'm all yours.
Thank you so much, Luis. And you know, I was thinking during your presentation, if we had a lot of answers 2 hours ago, now we have a lot of questions.
I didn't help at all.
Now we have a lot of questions, man. So, yep.
Okay.
We all know about things now, but we have questions about them. I have some questions, but first let's have the questions from the people with us. So Mihai Marco is asking, can you measure lactate after you administer ringer lactate? Well,
yeah, there is some studies about that, and the impact of lactate when you infuse lactate over the serum lactate is very minimal. The lactate, when you give it, think about this, you give it in a vein here. That thing immediately goes to your systemic circulation and goes immediately through the liver. The liver turns that into bicarbonate. So when you take the sample, that is return. That is blood coming from your tissues. So the real impact of lactate over lactocythemia is minimum. There's some very nice questions about it. It looked like each individual process lactate in an individual manner. Because, for example, patients with cancer tend to have more lactate than patients without cancer, because the cancer cells seems to use anaerobic mechanism who produce lactate more faster. So it's not perfect, but it's a good alternative.
Okay. And another question, thoughts on fluid of choice in salt intoxication?
Oh, shit. Yeah, sorry. With salt intoxication, like a dog drinking ocean, the last that I saw was a dog drinking ocean water. The Oregon coast, they have a lot of beautiful, enormous cold water, and dogs love that. And this dog drink a lot of ocean water. What we use still is a very small amount of hypotonic. So we mix saline with dextrose 2.5, and we go really slow. When you have hypertonicity or hypotonicity, the correction of the sodium has to be very slow, okay? Essentially, the main problem is the cells on your brain adapting to this environment with a lot or almost no sodium.
Okay, that's clear for the moment. So I think one of the most important things in the world is pay attention to sodium and chlorine. So especially chlorine, if we talk about resuscitation fluids, because we used to use a lot of saline in the past. So
I mean, let me interrupt you one sec. If you're gonna use saline for a castration, or while you do a dental or something that you're gonna use it there's none to make a difference. The difference is if you're gonna use a fluid aggressively because your patient is really, really sick, that is when it makes a difference. Do not use saline if you're gonna provide an aggressive fluid therapy. That's the message.
Yeah. Karina has one question. How do you treat AKI in braces like fluid-wise? Doses based on dehydration or fluid losses? Is this resuscitation or maintenance?
It depends. I mean, well, you're here, you know the answer of this.
Yeah,
It depends a lot.
from case to
In
case,
general,
you adapt them.
what's
Yeah.
with chronic, I mean, with what you try to do with acute kidney injury, and I'm going to put a dog who was intoxicated with raisins or grapes or NSAIDs. We have those cases many here. What we try to do is provide volume normal. The classic approach to give excessive volume to produce fluid lavage and stimulate diuresis is very controversial today. So we don't put excess of fluid to make the kidney work on acute kidney injury. There are some questions about if that produces more damage. We have one advantage. We can produce a renal therapy. We can produce renal replacement. But if you don't have, just provide fluid therapy to remain normal, and you can use eventually some osmotic agents like mannitol and provide some antioxidant therapy. But do not give a lot of fluids on those guys. There's no point. We used to do that. I don't know. My dog ate the whole bottle of ibuprofen. And what we used to do is put a catheter and give liters and liters of fluid in what we call to protect the kidney. And that has been proved that it's not true.
Yeah, that might be worse than doing nothing.
Yep.
We have the same approach here. So basically, it's like she asked the question if it's resuscitation or maintenance. My opinion is more maintenance than resuscitation. When we talk about AKI, it's a lot of calculating the sodium, potassium, chlorine levels, dehydration degree, and maintenance all the time. So don't over-treat the AKI patients because the damage is already made. So you need to protect the kidneys. That's my approach.
Yeah, overload fluid is more dangerous than underload. Let's put it that way.
Yeah, that's even better. Mihai has another question. What do you think about combining hetastarch with hypertonic saline for fluid resuscitation?
I mean, we got a problem in the United States. We got a problem, and the main problem we have here is named lawyers, attorneys. If there is a study who proves that colloids like hetastarch did damage in a published study, so it's public, and you do it, you're liable.
Yeah.
That's the reason why doctors here do not use it. I still think that there is room for the usage of hetastarch, and I would love to use it. And I have a form of consent waiving for the clients if I'm gonna use it. For septic patients, I truly believe that you can use it in a very limited amount. And I think the problem was the amount of volume that you give. We used to give 20, 30 mLs of hetastarch per kilo in a day. We are using 2 or 3 mLs now. But the problem with that today here is if something happened and the dog died, somebody can sue you. And you have very, very bad position to defend yourself because there's published articles who say don't use it. Make sense?
Yeah, it makes sense. You don't have any studies with you, you're alone. So
yep. And lawyers are there, they can smell blood.
Yeah, you know me, you know the way how much I love to do selfies with you and people. Well, that's a new way of doing selfies like this.
How do we do this?
I do this.
I don't see anything.
Yeah, you see this is my phone here.
Yeah.
And I'm doing a selfie now with you.
Okay.
I'm joking. Thank you so much. It was really, really full of new things for a lot of people. I received a lot of messages. They told me we had questions before, but now we have more questions, which is good. And hopefully we'll get more answers in the future. The more you read, the more questions you'll get, guys. So that's the only thing. So read, but you know, we have the same problem here in Romania with the lawyers. What we do for the moment is get consent from the owners. So we just explain them that's a desperate case. You need to do that. It's not in the books, but you have to do that. So if it's not in the studies and you're doing it, just get the consent from the owner. That's the smartest thing you can get. hopefully we'll meet again healthy, and we'll see each other again in flesh and bones. Thank you again, Luis, for your time. Thank you guys for being here. Hope to see you soon, and hope to meet you, I don't know when, but hope to meet you again in flesh and bones. Good night for people which are
Thank you so much. Thank you to everybody, and I really love it. Okay, be safe, guys. Take care.
Thank you so much. Bye-bye.
Bye.